I'm calling the meeting of the Health Insurance Reform Commission for dated Tuesday, April 18, to order. And we'll have, I guess, a calling of the roll. We don't appear to have a quorum right now, but we'll manage, I think, because I don't think we have any action that we have to take in voting today. So, Tom, do you want to call the roll, or who do that? Okay.
Delegate Ware, Delegate Byron, here. Delegate McNamara, Delegate Sullivan, here. Senator Surville, Senator Saslaw, Senator Spruill, here. Senator Barker,
here.
Secretary Littell, Commissioner White. You have a quorum, Mr. Chair.
All right, thank you. We will start with legislative update with Tom Stevens presenting that.
Thank you, Mr. Chairman. Just a quick rundown of bills related to health insurance that passed this year, as well as a few bills that were referred to the Commission. HB 1375 and Senate Bill 1011 by Delegate Greenhall and Senator Edwards. It's on health insurance. The tobacco surcharge would eliminate the authority of a health carrier to vary its premium rates based on tobacco use. The bill requires an annual report and has a 3-year sunset. HB 1640 and SB 1409 from Delegates Kilgore and Senator Barker. This would require each insurer issuing Medicare supplement policies to offer the opportunity of enrolling in at least one of its policies to any individual under age 65 and is eligible for Medicare by reason of disability. HB 1471 and SB 1261 from Delegate Fowler and Senator Dunavant. This is about electronic prior authorization and requires carriers beginning in 2025 to establish and maintain an online process that links directly to all e-prescribing systems and electronic health record systems, can accept electronic prior authorization requests, accept and approve those requests, and also to link directly to real-time patient out-of-pocket costs for the office visit. HB 1739 and SB 927 from Delegate Head and Senator Favola. This bill requires the Bureau to convene a work group to develop recommendations for any necessary changes to improve the process for determining if a carrier has failed to implement minimum fair business standards. That report will be submitted by December 1, 2023. HB 2201 and SB 1171 from Delegate Byron and Senator Dunavant on association health plans. This provides that for association health plans, an insurer may establish base rates formed on an actuarially sound modified community rating that considers the pooling of all participant claims and allows the insurer to utilize each employer member's specific risk profile to determine contribution rates. HB 2216 and SB 1347 from Delegate Lefwich and Senator Cosgrove. This requires carriers to provide coverage for mobile crisis response services and support and stabilization services provided in a residential crisis stabilization unit. HB 2262 and SB 1154. This requires a carrier that credentials physicians or other providers, mental health professionals or other providers in its network to establish reasonable protocols and procedures for processing of new provider credentialing applications. HB 2354 from Delegate Orrock. This is on continuity of care. It makes various changes to provisions related to the continuity of care, including extending the term by which folks whose provider has been terminated from the network can receive care from the same provider. SB 1003 from Senator DeSteff This is a bill that came to HERC a few years ago. It had passed, but was prevented from becoming effective because of budget language. Passed again this year. Health insurance, mandated coverage for hearing aids requires insurers to provide coverage for hearing aids and related services for minors. And then there were two bills that were HERC recommendations dealing with essential health benefits. The benchmark plan, the first, HB 2198 and SB 1399, carried on behalf of the Commission by Delegate Byron and Senator Serval, requires the Bureau to select a new essential health benefits benchmark plan for 2025 that includes coverage for prosthetic devices and formula and internal nutrition products. The Bureau will go into more detail on that bill. The other HERC recommendation also on Essential Health Benefits Benchmark Plan, HB 2199 and SB 1397, again carried by Delegate Byron and Senator Serval, establishes a review process for a HERC review of the Essential Benefits Benchmark Plan. Below on your sheet, I've got a step-by-step of that process, but I believe the Bureau is going to go into more detail on that, so I will let them do that next. In 2023, a number of bills were referred to the Commission, HB 1538 and SB 1273. This came from Delegate Clark and Senator Boysko. Regarding doula care, requires carriers whose policies include coverage for obstetrical services to provide coverage for doula care services. HB 1918 and SB 1157 from Delegate Batten and Senator Marsden. This would require carriers to provide coverage for the cost of health care services provided through audio-only telehealth services for certain counseling interventions. HB 1815 from Delegate Simons. This requires health insurance coverage to provide coverage for diagnostic breast exams and supplemental breast exams. HB 2206 from Delegate Kilgore regarding proton therapy. This requires carriers to consider coverage for proton radiation therapy by Medicare, Medicaid, or any other governmental health coverage, or a recommendation by the patient's provider as a sufficient standard of clinical evidence to justify coverage of proton therapy. And then finally, Senate Bill 1301 from Senator Deeds regarding M-CHIPs and network adequacy for mental health care, requires M-CHIPs to provide a sufficient number and mix of services, specialists, and practice sites to meet covered persons' mental health care needs, ensure they have access 24 hours a day, 7 days a week, and incorporate strategies to facilitate utilizations of the licensee's healthcare services. Also, just as a reminder, two bills were referred to HERC in 2022 that you all are still working on. HB 2040 from Delegate Dawn Adams, requiring an insulin discount program for health insurance, as well as HB 477 from Delegate Austin, which prohibits cost-sharing requirement for prostate cancer screening.
Mr. Chairman,
All right, Delegate Byron.
I didn't realize we did so much work during this session. This is it's quite a few bills here. At first, I thought they killed my bill in the beginning, and those are bills that passed. So, but we actually passed a lot of stuff. Got a lot of work to do.
Yes,
Thank
so, any other comments or questions? All right. All right, if there's no comments or questions, then we can move on to the next item on the agenda, which is an update on the application for new essential health benefits benchmark plan. Julie, coming forward here, so.
Okay, thank you. Good afternoon, Mr. Chair and members of the Commission. My name is Julie Blavelt. I'm the Deputy Commissioner at the Bureau of Insurance, and I'm here to present to you some information on the Essential Health Benefits Benchmark Plan. So just a little overview of what we'll talk about. We'll just do a quick review of EHB requirements, because I know all of you all are familiar with that. And then as Tom just presented to us, there was Virginia legislation related to the EHB requirements. I'll give you an update on the EHB benchmark plan application and process, and talk about the comments that we received during the public comment period on the 2025 benchmark plan application, and then talk about the review process that will occur based on the legislation that passed this year as well. So back in 2014 is when the ACA imposed requirements that states set the benchmark plan, an essential health benefit benchmark plan that sets out the main benefits that have to be provided for individual and small group health insurance coverage. And each state had to set their own benchmark plans. And then in order to adjust those benchmark plans, the federal government has set parameters around how much a state can move those benchmark plans and change the benefits that are in those benchmark plans. And this is because of the tax credits, the subsidies that are provided to individuals that are in qualified health plans that the federal government is paying for. So they want to put some parameters on how much those benefits can be adjusted within that coverage. Of course, states can mandate benefits that are outside of essential health benefits. And when they do that, then the state has to defray the costs of those benefits. And just to give a little perspective on the coverage or the amount, the size of the individual and small group markets, each of the markets are about 3.5% of Virginia's population. The individual and the small group markets are around 315,000 people in those markets. And then so together they make up about 7% of Virginia's population. All right, so in addition to or mirroring the federal requirements, Virginia did impose Virginia law about essential health benefits and requires those benefits. So we saw, as Tom mentioned, two sets of bills going through the session, one that set the benefits that the Bureau of Insurance would select to be in the EHB benchmark plan for 2025, and then another one that set out the process for updating the benchmark plan in years after that. All right, so based on the requirements of the legislation that passed, House Bill 2198, Senate Bill 1399, the Bureau of Insurance did create a EHB benchmark plan application, and you can view that application at the website. That's on this slide. And the guidelines that were part of that legislation is that we use the existing benchmark plan application, the existing EHB benchmark plan, which was one of the more popular, the most popular Anthem small group plans at the time. When this became about in 2017, that's where the benchmark plan that's there now came from, back in 2017. Updated requirements from the federal government require us to take out all of the Anthem information, all of the information from that Anthem evidence of coverage that was the benchmark plan, and just show the benefits. So take out all of the other stuff, take out all Anthem identifying information, create a new document for this application that just sets forth the benefits, but don't change them from what they were, except for the ones that we are changing. So we created the new benchmark plan that has the same benchmark plan benefits. We added in the two that were included in the legislation, the enteral nutrition and the expanded prosthetics that are already being covered in the large group markets. And we also updated the benchmark plan up from what it was, back in 2015 when the plan was chosen, really, to include updates for federal laws like MAPIA, mental health parity, non-discrimination, state and federal laws, any provider mandates that the state has passed, we can update that without cost because that's not considered an additional benefit from the federal government. So we did all that, we made all those adjustments, and that is what is in the current draft benchmark application. So here's just a little overview of how the process has gone so far. The governor signed the law into effect on March 22nd, and so since it was emergency legislation, went into effect on that date. Within a week after that, we posted the draft EHB benchmark plan application that will be for 2025 on our website and issued a news release the day after that announcing the public comment period that would last for a little over 2 weeks till April 12th is when the public comment period closed. And so we have the deadline to submit the final EHB application is May 3rd. And we will be able to meet that. And so what we'll do after we submit the application is we'll work with CMS to make any changes that they think should be made, any other updates that they think need to be made, and then we should have the final approval, hopefully by August, probably summer sometime. And then that will be effective for 2025. Then just to give you a little update on the comments that we did receive, because the legislation that sets how the benchmark, what the benchmark plan is going to be for 2025 was very specific, and we'd already done the research as to what the benefits were going to be, and there needs to be an actuarial analysis that supports the application you're making. The benefits pretty much had to be set by the time we did this comment period, but we did feel like any comments received would take into effect for future reviews. So one comment we received was from Virginia Poverty Law Center, Sarah Cariano, and just was expressing concern that the process that was established for the Bureau of Insurance to make the selection of the benchmark plan being based on a legislative process, and the HERC process wasn't sufficiently based on data and complaints actually received, and isn't flexible enough to address any kind of health emergency situation like opioid epidemic, as some states have done to change their benchmark plan. So we think those are helpful comments at the Bureau of Insurance, and we will take those suggestions. They had suggestions about the makeup of the work group. Their comments were more based on the process going forward than the actual benchmark plan that is set now, because I think they understand the process as it is now, but we will take that into consideration when the Bureau does the work group, and the information that the work group looks at. We will try to follow their suggestions of looking at data and complaints to come up and provide recommendations to the Health Insurance Reform Commission in our report that we're going to give to you on March 31st of 2025, the next review year. And then we just had one other comment, a concerned citizen that was objecting to defining formula as medicine. So based on those comments that we received, we are not planning on making any changes to the draft benchmark application that is out there now.
Mr. Chair? Yes. May I ask a question?
Delegate Sullivan.
Thank you. Ms. Bloveld, so
Yeah.
I think you answered my question in your last two sentences there, which was, During this 2 weeks, we got 2 comments,
Yes,
total of 2.
yes, that's correct.
Thank you.
Uh-huh. Okay, so this is just a slide looking at the process for the Health Insurance Reform Commission now. When there's a proposed mandate, the legislation that was passed, House Bill 2199, made some changes to the HERC process. So just to make sure the commission is aware, I think the main point is the changes in the blue box at the end of this process. Everything else is pretty much the same following the Bureau's Step 1 analysis there in the green box, where we answer the question of whether the proposed mandate exceeds the scope of essential health benefits. The bill provides, or the legislation now provides the law, provides the Health Insurance Reform Commission with more options than to just, move the bill to a Step 2 process. The Health Insurance Reform Commission can consider that proposed mandate after we say, yes, we think it does exceed the scope of the EHB after the Step 1 analysis. The bill could be moved to further study as part of the next essential health benefit benchmark plan. Of course, we still have that second step that HERC has always had to do further analysis under the Step 2 and make it a proposed mandate in Virginia, or something else. And the something else could be, it's a proposed mandate, but only in the large group market, possibly.
All right.
Okay. And then this slide is just kind of giving you the steps that are going to happen when we look at the next EHB benchmark plan review and potential update process. So the next review year will be 2025, and that's set out by statute, and then every 5 years after that. But prior to 2025, the Bureau is going to start this working group that we talked about. And we're going to present the recommendations from that working group, along with any analysis that the Bureau has done from previous HERC proposals that have been passed on to us for further assessments. And we'll include all of those recommendations in the report that's due on March 31st of 2025. And after that, the Health Insurance Reform Commission should hold 2 public hearings prior to the Health Insurance Reform Commission deciding by the end of June whether or not there will be any changes to the benchmark plan. And also by that June 30th meeting, the Health Insurance Reform Commission will let the Bureau of Insurance know what benefits they want studied further for actuarial analysis for inclusion in the next benchmark plan. And if the Virginia is going to move forward at updating a benchmark plan again in 2025, then HERC will hold 2 more public hearings to discuss the actual benefits, and the Bureau will be doing that analysis during that time. So between June and December, there'll be 2 more public hearings that HERC will hold to discuss the benefits. And the Bureau of Insurance will provide its actuarial analysis of those benefits by the end of September. And then by the end of December 2025 is when the final changes are going to be, there's going to be a determination about the final changes to be made to the, and recommended in legislation to the Essential Health Benefits Benchmark Plan this would be for 2028. Is
Right.
what that would be for. All right, so breaking that all down, and a final summary is the Bureau of Insurance is going to finalize the benchmark plan application for 2025 and submit that with basically no changes from what the draft application is posted right now on our website. We should get a determination, we'll work with CMS, we should get a determination by the end of the summer on whether our 2025 EHB benchmark plan is approved. And then, in the meantime, HERC will operate under the new process of deciding what to do with new mandates that go through step 1. Do they go through the step 2 process? Do they get sent to the EHB for consideration under EHB review or something else? And then during 2024, the Bureau will start assembling the work group and getting information on the recommendations that we get from HERC in order to get that report to the Health Insurance Reform Commission by the end of March 2025 to start the next EHB update review process.
All right, thank you very much. That was quite thorough, but it looks like we have been doing some good work here, so that setting up the process and getting it moved forward. So, are there any questions or comments anyone wishes to have? So,
Mr. Chairman,
yes.
this Rob Bloxham. I do have a question about how this affects ongoing budgets as to what control we have over the cost. Is this, I'm assuming if we aren't original at this, I'm assuming there's a actuarial type trail that we can follow to kind of understand the cost on our outgoing budgets.
Rest, you want to respond on that and what we do in step 1 and step 2, those types of things. So.
Yes, we have a budget to work within, and the analysis. The state has done an analysis on the cost of the additional benefits that are being added, and it's well within the limits that the federal government has set. And so the cost of the benefits is the increase in premiums to the essential health benefits. So when you're just changing the essential health benefits in the benchmark plan, that's not a cost to the state. It's only when the state proposes mandates that will not be part of EHB that would actually be a cost to the state for those.
Okay, all right, thank you much.
All right. Any further questions or comments? So, all right. All right, well, thank you very much. I appreciate that.
Okay,
So,
thank you.
and we will now move on to item 4 on our agenda, discussion of the Commonwealth Health Reinsurance Program. So,
Good afternoon, Mr. Chair, members of the Commission. My name is Brad Marsh. I'm the Health Insurance Policy Advisor with the Bureau of Insurance. Today I'm going to talk to you all about the funding of the Commonwealth Health Reinsurance Program. We are currently in our first year of the program, and within the next short period of time, we have to set the parameters for the program in 2024. So just to give a little background on just the idea of reinsurance, it's a mechanism for spreading costs of expensive claims. Groups of insurers pool together so that they use a separate financing system, sort of smooth that, to smooth those higher costs out so they don't have to price those costs into their standard premiums. The SEC was directed by code to apply for a waiver with the feds under Section 1332 of the Affordable Care Act to both permit and to help fund the reinsurance program. This waiver application was submitted December 30th, 2021, and we received approval for that program on May 18th from the feds, and the program then, per state code, became effective on June 18th. It's approved for 5 years beginning in 2023. So just a little bit on how reinsurance works, or at least works in this environment here. There's an attachment point under which the reinsurance program doesn't pay anything out for any claims for individuals. There's a cap over which there's no payments for the reinsurance program. And then in that band, those claims eligible for reinsurance, they would be reimbursed at a coinsurance rate, so not 100% reimbursement. These are the These are the parameters that we're currently under in 2023 for this. So we have a 70% coinsurance rate. The attachment point is 40,000, and the reinsurance cap is 155,000. These are the parameters that were set, seeking a 15% reduction in premiums in the individual health insurance market. I wanted to make one note here as we go through this presentation. We'll be talking about plan year and fiscal year. So plan year is just going to be your calendar year in which those insurance plans are covering folks here, and then the fiscal year is going to be our fiscal year here. And I've tried to do a good job of differentiating between those two.
Mr. Chairman, can I interject a question?
Yes,
Because I'll
David.
forget it if I don't ask it
Sullivan.
now. Mr. Marsh, could you, the 15%, so that's the target that this exercise is meant to accomplish, is to reduce premiums by 15%?
That's right. Based on the actuarials that we were presented when we initially filed the waiver, we were seeking a 15%. It actually was looking for about a 15.6% reduction because 15% is what we reduced to the program, and then there's an idea that bringing more folks into the market lowers the morbidity rate, and that adds that extra 0.6% in the actuarial analysis there.
Thank you, sir. Thank you, Mr. Chairman.
Certainly.
So here's just a little bit on, we talked about that we had to get approval for the program to allow it, but the main part of getting approval for the 1332 waiver is that we get federal pass-through funding, which funds a large percentage of the program. And that federal pass-through funding is provided to us based on savings that the federal government receives from reduced premium tax credits due to the fact that the top-line insurance costs come down. So these premium tax credits, they're designed to bring an individual's sort of out-of-pocket premium cost down to a particular percentage of their income. When you lower those top-line premium costs, those tax credits are allowed, then can be lower and still achieve that goal. And so an analysis done by the federal government based on information that we provide to them, they do that analysis, and then they provide us funding in the amount of those projected savings. In this arrangement, Virginia's estimated state share is largely driven by individuals who purchase health insurance coverage without the premium tax credits, because those are things that we still have to pay for, at least actuarially in the program, but that the feds don't see any benefit from, because those folks are not receiving premium tax credits. Those premium tax credits aren't then reduced, and so we're sort of responsible for the whole boat of those folks within what the state share is. Now, just to say, this is all based sort of prospectively on actuarial analysis, and then the actual costs of this don't come until after we have the experience of the program. In August 2021, in preparation for our waiver application, BOI's contract actuary completed their first actuarial analysis of reinsurance program costs. They provided us with several different scenarios, 5, a 10, a 15, and a 20% premium reduction scenario, and showed us costs, overall cost of the program estimates, the state cost, as well as the federal share of that cost. BOI presented these scenarios in order to choose one, which we had to include in our waiver application. We presented those to the bill patrons as well as some money committee members during the fall, and they selected a program cost of $68.63 million, which was a 15% premium reduction target that they believed that the GA would fund. We certainly didn't want to put an application in for something that was outside of what the General Assembly was willing to put into a budget for it here. And so we submitted this waiver application based on that 15% scenario. These are the numbers here that were in the application that we submitted here. As you can see, that 68.6 number in plan year 2023. Those state costs come directly out of the general fund. Other states have done programs where they take part of the assessment and have the industry pay for it, but the design of this program under the state law is that we pay for these out of general funds. These are sort of look like point estimates, but have a range and have sensitivity to different underlying elements that can come inside of them. And just to note that these are plan year numbers. So for each of these, the actual incurring of the cost would occur in the fiscal year following that plan year. So for plan year 2023, those funds are in fiscal year 2024. During the time that basically from when, I guess it happened slightly before the bill passed to do the reinsurance program here. After COVID, we had the American Rescue Plan Act. It was passed in March 2021. And it expanded the tax credits that were available to folks. Those under 400% of the federal poverty line received enhanced tax credits. They were actually they couldn't pay more than a smaller amount of their income than they had prior. And then those over 400% of the federal poverty line who prior to this had not been eligible for any premium tax credits were eligible for premium tax credits to the degree that they reduced their out-of-pocket to below 8.5%. So they were limited to 8.5% of their income as to what would then be covered by tax credits. At the time, these enhanced payments were set to expire prior to plan year 2023, the first year that we were proposing our waiver program for. So when we worked with CMS on this, knowing these sort of changes that were coming, we inquired with them about how we should submit this, and as one would probably expect, they wanted us to submit the waiver application based on the law that existed at the time that we submitted the waiver. Even though that was the case, we thought there was a high likelihood that these enhanced premium tax credits would continue after or through 2023. So we put together a statement of work for our contract actuary, and they went through and did an analysis based on if those same ARPA extended tax credits were continued into 2023, and provided us an analysis of what the program might cost under a program like that. They drastically reduced the estimated state share of the cost of the program. As we talked about before, the federal cost or the federal pass-through money comes from savings from those premium tax credits. So enhanced premium tax credits mean more savings for the federal government on the back end there, and mean that those savings mean that the state ends up taking a smaller share, at least in the design of the way that the analysis was done here. And so they drastically reduced the state cost of the program to under $20 million. In working on plan year 2023 state funding during the 2022 session, we needed to make sure that we had this money secured in the 2024 budget. And we talked about the payments are going to go out after the year's done. So we worked with Money Committee staff and legislators about this funding, but the program itself the reinsurance program itself hadn't been approved by the federal government yet. And we did advise on the fact that there were these underlying policy changes that could affect the cost, and we provided a little bit of information on what we'd gotten both from our original analysis and from our analysis of what would happen with those extended tax credits. At the end of session, neither the House nor the Senate approved budgets had funding for the reinsurance program in them. However, sort of during the intervening time between session and the budget bill actually getting signed, the program was approved on May 18th, and the law went into effect then in June. On June 22nd, the conference budget was signed by the governor. Or that's not actually true, but sorry, the final budget was signed on June 22nd, and it included $20 million in funding for reinsurance. In August, the Inflation Reduction Act was signed into law, which extended those ARPA tax credits for 3 additional years until 2025. Once this occurred, we confirmed to federal regulators that based on the second analysis that we'd done, the alternate analysis that we'd done, that the $20 million would constitute a full funding of the state share. And so the importance of that is that that allows us to access the federal funds at the earliest point in time that we can. They won't provide access to those funds until they see the state ponying up their share. In August, we presented our ACA individual premiums, lower claims cost for insurers due to the reinsurance program, reduced rates by about 19.5%. That is just looking at the impact of reinsurance. The trend would have had those costs going up about 2%. So the net result of reinsurance was to lower the cost by about 17.5% there. Just a little bit about sort of how the program works and who sees benefits from it here. It's the subsidized individuals on the exchange generally don't see much of a difference in their out-of-pocket costs on that, because that's where we're sort of funding the program from. Their premium tax credits are going to be reduced in whatever the amount that the reduction in premiums are there. So as a result, they don't really see very much difference in terms of their out-of-pocket cost. The folks who do see a difference are these unsubsidized individuals out there who then get the benefit of that full reduction in premium cost there. And also uninsured individuals who have not looked at the marketplace may look at that and find that those premiums are now something that are more affordable and allows them to enter the individual healthcare market. In preparation for our 2024 program and looking at parameters for 2024, we sent out a request to the carriers in February of this year to get information on enrollments and claims and tax credits down to a very granular level so that we understand what metal levels people have, what they're doing, who's receiving premium tax credits, how much, and this all comes from our carriers there. And in March 15th of this year, we received those, and so our actuary has been working on these numbers up until last Friday here, trying to do that analysis of what the cost of the program is going to be for plan year 2024. During the intervening time there, we also received information on our pass-through money from our pass-through funding for 2023 from the feds, or at least preliminary information on that. The information that we received from that February 2023 carrier data call showed that marketplace enrollment figures for 2022 and at least early plan year 2023 numbers showed substantial unexpected growth versus the estimates that we had back in 2021 that we built the waiver off of there. The overall enrollment in individual in the ACA individual market increased 17% over the original model. From around $300,000 to I think close to around 300,000 individuals to around 350,000 individuals there. And what's I think more sort of striking here is that the estimates of the enrollees that were not receiving these premium tax credits increased 50% over the original model, from around 40,000 to around 60,000.
Mr. Chair.
Yes, Delegate Sullivan.
Thank you. Is there a explanation or a guess as to why these numbers went up? The unexpected increase?
Mr. Chair, Delegate Sullivan. So there's a few things that could have played into this. Certainly in the 2023 year, folks that would have seen these would have seen the reduction from the reinsurance program as sort of the actual cost of the program, and might have seen sort of less benefit from the premium tax credits than they would have, or may not have availed themselves of those tax credits. There's also the ability of folks to purchase these same plans off marketplace, and then they would not be able to then avail, there would be no system in place to avail themselves, at least of the advanced premium tax credit side. I believe they can on the back end apply and get those tax credits potentially there. So there's sort of two questions within that. One of them is, why do we have so many more people? And the other is, why aren't they getting premium tax credits? We don't have a lot of information on why that, so we can just we can think about the fact that we've driven down the costs. That may drive also down sort of the benefit of going ahead and applying for those benefits. There may be folks that do not know that they're eligible for these premium tax credits. Since we've had this expansion, they would not have, if you made over 400% of the federal poverty line, then you would not have in past years been eligible for those. You might not have thought it was worth your while to put your income into the marketplace application and determine whether or not you had that. We don't have any information right now in terms of specifically why that is the case. I will say that we will likely have better information in the future on this once we move to a state-based exchange, because we will have a little more access and a little more visibility into that underlying data. So our actuarial models produce a best estimate, and I think what's very important to note here, along with a range of variations based on changes in underlying assumptions, like what we discussed there about growth in enrollment, people receiving premium tax credits. Also, if the claims come in, they give us scenarios where if the claims come in 10% higher than we thought they would, or if overall premiums are reduced more or less than we look at, those can affect the calculated estimated costs on these. It's a note, as we sort of said before, that the non-premium tax credits employees have a pretty substantial effect on the overall state cost of the program, because we're sort of carrying the full boat for them. And the state essentially doesn't receive pass-through funding based on the existence of these individuals, because the feds don't have any savings that come from that. The model for plan year 2023, so this first year that we have, the one that we've already started into here, that was produced back in 2021, but included those ARPA subsidies, those enhanced premium tax credits under ARPA, or under, Inflation Reduction Act, estimated that if that the state cost increases 25% or $4.8 million for a 10% increase in these non-premium tax credit enrollees. Based on the experience in 2022 and 23, the current model is estimating that the non-premium tax credit enrollees to be about 48% higher than the 2021 model that we built those costs off of. So though it's not a huge sort of number, it's only 20,000 folks within this market of 350,000 people, because the main cost is coming from that small group of people, increasing that group by 50% has a pretty marked effect on the cost of the program, at least for the state. So based on the model that we have now updated with the actual market experience, the state share of the plan year 2023 reinsurance program is estimated to be around $43 million. Now, I want to note that these numbers are based on what we see out in the marketplace, the enrollment that we have out there in the marketplace, but the actual program costs that we have are going to be based on the claims that actually come in from carriers on folks that exceed that attachment point and how many folks do that. We won't know those final program numbers until early June 2024 when we get the final numbers from the feds on what has gone on in 2023. Now, we will get reports from our carriers over the course of the next year, quarterly, that will estimate what sort of the claims that they have, so we'll see how they grow throughout the year. But I would assume that a lot of the costs or a lot of people end up going over that limit in the latter half of the year there. So it probably won't be until at least after that year is done that we have a really good idea of what our overall costs of this program are going to be. So to the task of setting plan year 2024 parameters, as we noted, the program parameters were set for 2023 at the points that we showed on slide 5, based on our waiver application that was developed in August of 2021. For the next year, for plan year 2024, per state law, we must establish and publish the payment parameters by May 1st of this year. And that's sort of structural. It's not just legislatively needed, it's kind of structurally needed as well, just because of the time period between that and when we need to actually have the rates out there. And so the submissions that we get from rates have to be based on the existence of this reinsurance program. That's how the rates go down, is that the carriers look at the reinsurance program that's in place, use that to estimate what sort of savings they would receive from that, and then lower their premium costs based on that. Per state code, the SEC is supposed to consider the following factors when setting parameters, like premium rates, individual market participation, improved healthcare outcomes, impact on impact of high-risk individuals on rates, and lastly, and probably most importantly, funding availability. As a result of the changes that we talked about in terms of changing the 2023 costs, the state cost estimates for the plan year 2024 reinsurance program are more in line with those costs than the lower estimates that we created prior to program approval that took into consideration ARPA. They are lower than the cost that we estimated that did not include the existence of ARPA. So they've got sort of two elements working together here. We've got these enrollment changes that are sort of that are potentially driving things up, and then ARPA that's sort of driving them down at the same time. So we sort of assume, I think the assumptions that sort of didn't play out going forward were that that things would look like 2021 by 2023, and there have just been very drastic changes in the enrollment there. In terms of the assumptions about ARPA, those did come through. That program came through essentially as it was modeled. It's just a matter of that the behavior of folks in the individual market. We just got a lot more people than we thought, and a lot of them are not getting premium tax credits. So these are the estimates that we received last Friday from our contract actuary on the plan year 2024 reinsurance state costs. I wanted to highlight them as ranges here. And So for a 5% premium reduction, we're looking at costs between 36 and 64 million, all the way up to, at a 20% premium reduction, we're looking at costs between 43 and 98.8 million. And these do all sort of still exist, these ranges, within a 10% increase up or down in most areas of things like enrollment and things like that. So you could see numbers that were potentially outside of this, particularly if different parts of the sensitivity analysis, different underlying elements that compounded each other sort of work together. So if you had increases in enrollment and increases in the enrollment of folks without PTCs, and say increases in the number of claims that came in, these could all affect us positively or negatively, depending on how things actually play out. Just the nature of doing actuarial analysis and of trying to estimate things, far in the future of when they actually occur. So I wanted to note that the subsidized individuals do see not a whole lot of difference in their out-of-pockets because their premium tax credits are reduced in line with the rates. But we do expect to see these non-PTC individuals move on to the exchange from these off-exchange plans. They may be unaware of the enhanced tax credits that are available to folks, over 400% unlike before, and the reductions in premiums due to reinsurance, as we noted, may be diluting the value of going and applying for premium tax credits because the top line number on their premiums is so much lower than what it would have been prior to the existence of the program. So I just wanted to hit here on a summary slide, and then I'll be open to questions from you all if you have any additional ones. The nature of the reinsurance program and how we pay in our state budget program means that we need to do cost estimates far in advance of expenditures. That said, we won't need to do that type of analysis so far in advance as we did when we had to apply for the waiver. Now we're looking at a shorter period between the time when we're estimating and the time that we're actually going to be executing the program. So we would hope that we would be closer to knowing these things. Guessing the way the environment is going to be out 18 or 24 months is a little bit different than working on it out 12 months. There have been major federal policy changes, and partially as a result of that, some enrollment changes since 2021 that have affected the estimated reinsurance program costs for 2023 and 24. And that's the extension of the enhanced federal premium tax credits, and also the increase in the overall enrollment there. And then just to remind you all that we will need to select these parameters by May 1st, 2023 to sort of get that into the process of setting rates for 2024. And that's the end of my presentation right now. Please.
All right. Thank you very much. Are there any comments or questions? Yes.
That's what we're talking about, yes. Same question. Yeah.
So at least in the way, I'm sorry, Mr. Chair, Delegate Byron, the way that it's set up, it seems to give the responsibility to the SEC to make those decisions or to choose something based on consultation, certainly with legislators. We need to make sure, since we're not going to be the ones making the decision on how much money's in the budget for these sort of things, that there's support for these policies, because we put the program in place and then we fund it, and that's that can be problematic from a timing standpoint.
If only we could do everything in the budget that way, so. Okay.
I had a question about the very first thing you told us when you were talking about the patrons of this bill. Who patroned the bill that got this through? Do you remember? Does anybody remember? Whose bill was this?
Actually, there were two patrons, Delegate Sickles and me.
And you?
Yes.
I've heard of those guys. Okay, thanks.
Yeah. All right. Would you speculate on slide 19 on the 15, presumably on the 15%? Would that be what we would be looking at again?
If we wanted to maintain sort of the same level of reduction that we've had in years past, Mr. Chair, then you would go for the 15% reduction. Right. Anything below that, or even going to 0%, is going to end up looking like a fairly massive rate increase. Right. That's going to come from that. So That's not to say that we would necessarily recommend that in any way, just to say that's going to be sort of the appearance of the program at this point, since we've already reduced it down, 17% last year. Taking the program away would look like it's actually going to be more than a 17% increase if you go back there. But even some of those lower levels would actually, still sort of look like an increase if you drop down to a 10% or a 5%.
Right. Yes, I did. Look at Brian.
So if you put something out there and it doesn't get funded, then what?
Mr. Chair, Delegate Byron, the way that the law is set up right now, if the funding in our fund did not meet the needs of the program, then we would do a pro rata reimbursement to the plans of based on if we got 70% or 50% or whatever, we would just reduce the payments out to plans by that factor. It would likely be problematic for the markets because they would have reduced their actuarial premiums down based on full funding of the program, and then would get money back for something less than that across the board. So carriers would probably have a difficult time with that, and I'm not exactly sure how they would go about sort of making up that difference because they've already collected the premiums for that year by the time they're getting their payments.
Yes. Senator Spruill.
So with all this planning you're talking about doing, put something out there, if it doesn't come back right, would it come back and y'all blame us for this?
Mr. Chairman, Senator, I don't believe that we would come back and blame y'all for this, no.
Thank you so much.
Only after your primary.
That's right.
One thing that I would note, and just something I wasn't sure about here, but that came through on this is that part of possibly one of the reasons why folks are not availing themselves of these premium tax credits is the drastic reduction in the premium cost there. If the program was doing less impact, there might be more of an incentive for some of those folks, to the degree that they are eligible for premium tax credits, to avail themselves of those premium tax credits. Basically, whatever amount the premiums went up would be the value of those tax credits to some degree for them.
Quick question for you. Given where we are right now, are you seeing the numbers of people who are enrolling through the marketplace going up? And
Mr. Chair, yes, that is I believe what we've seen in the data call that we've gotten, based on sort of because they have full experience from 2022 now, right. Completed, and they did get a month of 2023 enrollment that they used. I have not seen the underlying numbers in that because they just sort of build them into their model, but we could certainly get back to you on what they've seen through that in terms of what the actual growth is right. of the market between December 2022 and January 2023, since that's when most of your folks are going to come in during the open enrollment period during the
right.
fall.
Yeah, I think it would be very helpful for us to be able to see this because the part of the intent was to be able to get more people insured as part of this by being able to subsidize the rate, the premiums that are charged there, and that should logically provide an incentive for the people who had not been enrolled to get enrolled now. And are you seeing anything further with just the first part of 23 data as well?
Mr. Chair, yeah, we'll put those numbers together and we'll send those on to you so you can take a look at that. Something we'd like to probably look at as well.
Right.
We've been digesting these numbers over the weekend and
right.
haven't gotten too much into being able to dig into all of the details of the underlying actual numbers that they have there. But I think I can see that would be definitely
right.
very valuable to you all and a good point, Mr. Chair, in terms of being sort of victims of our own success here.
Right. All right. Thank you. Any other questions or comments? All right. Mr. Commissioner, do you want to weigh in on any of this or comment on it?
Just a quick question. This consumer behavior you've been discussing that as a result of our actuarial analysis, I mean, the assumptions not panning out in terms of the unsubsidized population, is that unique behavior to Virginia, or do we think that this is occurring in other states with reinsurance programs, or do we know?
Mr. Chair, I'm not sure, Commissioner, if that's something that we have in our analysis right now, but that would be something I think valuable to look into and see if this is a trend that we're dealing with nationwide, or if this is just something specific to the changes that we've made in our program, or something specific to the nature of Virginia.
Right. All right, thank you. Are there any other questions or comments? All right, thank you very much.
Thank you, Mr. Chair.
All right, next to last on the agenda is public comment. Is there any public comment?
Those in the Zoom room who would like to provide testimony, please raise your hand electronically. We have no online speakers, Mr. Chairman.
All right, thank you. Anybody else? All right, well, I do have one comment here. And sitting in front of me is Mr. Stevens, and he did not hit that three-pointer for Furman University when they beat UVA in the March Madness. But he did smile a little bit because of his alma maters taking down the big UVA. So are there any other comments anybody has here? So, all right, anybody want to offer a motion to adjourn? All right, all in favor say aye. Aye. All opposed, no. We are adjourned.